Hey everybody, so it has been a minute since I made my last video. I think I made it at the first week of my current course, which to kind of give you guys an update, currently I am taking my summer 1 class, which is Advanced Treatment Planning and Psychopharmacology. So basically what this course does is it kind of goes over the knowledge that we've gained so far as a counselor, our ability to do assessments and treatment planning, and also goes over the pharmacology aspect. Although we're not the ones that are writing the medications up, we can in fact make recommendations, or if we have a client that has been on medication or is currently on medication, we want to understand kind of what the psychological aspects are happening along with the influences on their moods, their body, their behavior, because since we are, kind of in a sense the first responders, we're the first ones that see these people more often than the prescribing pharmacologist. So with that being said, I kind of wanted to go over some things really quick. Well, I guess not really quick. So the beginning of this class is a dyad. So what a dyad is, if you guys are just watching this and you haven't watched any of my videos or any videos that are related to becoming a therapist or being a therapist, a dyad essentially is just a term for saying you're working in pairs. See, no big deal. Like if somebody says, "Oh, are you in a dyad? Have you ever worked in a dyad?" It's just saying you're paired off. That's really it. So I have a dyad partner, and in my previous videos, I've always talked about, oh my God, I have a partner. I'm in a group. I hate it. But for her and I, even though we have opposing schedules, it so far so good has been working. So fast forward. The first okay, so what we have to do, Camille, get your words together. I'm all over the place because I'm trying to get this video in before I have to do other stuff. So excuse me. But I will be precise and clear so that you guys understand what's going on and what you can gain from it. So for this class in our dyad, we have to do role plays. So what that means is, like, for example, say I was a partner with you, whoever's watching. I would at one point play the therapist and you would play the client, and then the roles would reverse. So in this instance, we had to each pick our own general disorder. So for me, I had picked alcohol, acute alcohol disorder. The girl that I'm doing, that's what she picked. See, I'm trying to get it all together because it's just like such back and forth. So basically the two things that we're both doing is somebody that's addicted to opioids and somebody that's addicted to alcohol. Boom, there you go. See, I don't know why I was trying to make it so hard. Anyway, so what we have to do is you really have to not only know about that disorder in order to be the therapist, but because we are doing role play and you want to be as authentic as you possibly can, you want to make sure that you are understanding what that person's personality type could be, what are the symptomatic personalities and the diagnostic criteria that would go with a person that is suffering from these specific disorders. So our first dyad role play, it consisted of about 30 to 45 minutes, and we had to go through what is called the Bio Psychosocial Assessment. So for any of you guys that are unfamiliar with that is, I didn't know what it was. You might know what it is. You might not know what it is in terms of that's what it's called, but you might be familiar with what the process is. So essentially what it is it's broken into sections. Usually this will be something that you do as a part of a person's intake paperwork, but just for the sake of us gaining knowledge on what the paperwork entails and then how to use that information on the paperwork to help the client in their first session, first or second session. So it's kind of broken up. There's the clinical assessment section. So what that goes over is it's like the patient's name, or not the patient's name, your name as the clinician. You never want to, on a clinical assessment, put a client's name. The reason for this is PHI, and you're thinking like, okay, but it's in my office, it's logged, it's in a file, it's secured, it's scanned. No, because in order to keep the identity of the client secure and safe, you need to give the client a ID number. So what you want to do instead of putting their name is give them a client ID number. Then you want to look at what the primary configuration is. So what that is this an individual person coming into therapy? Is it a couple, or is this an entire family? You want to know what the language is that the person speaks and understands. So if they're English, Spanish speaking, you want to mark those on there. You want to find out what their gender is. First of all, you never want to assume by looking at somebody what their gender is. That is a no-no. So you want to make sure that you are finding out what the person identifies with by either asking them or making sure that they're filling out this assessment paperwork. So you would have them fill that out, and then you would also have them fill out what their occupation is, because you want to obviously know if this is somebody that is working or if their occupation could be a factor in some of the symptoms that they are having in reference to depression, anxiety, aggravation, irritation, anger. Any of these things could be related to their work environment. So that kind of helps you understand what their environmental causes may be. You also want to know what their relationship status is, if they're divorced, single, widowed, dating. You want to know all these things because, once again, these are all factors that go into being able to properly diagnose and assess a client. You also want to know if they have any children, what the ethnicity of their children are, what their children's ethnicity is. You also want to know, the age, their gender. All of these things are pertinent because it helps you to better relate and understand your client instead of being assumptive, because making assumptions is a horrible thing to do, as we all know, but we are human. So this kind of allows you to not make assumptions and to gather as much information as possible. So if you're working somewhere, like let's say at a private office, and they might not necessarily have a biopsychosocial assessment as a part of their intake, and for your case conceptualization, you need to gather this information in order to write a case conceptualization. You're going to want to make sure that you're not just asking this person these questions like as if you're interviewing them. You want to make it very genuine. So that's what we had to do in our role play. We weren't allowed to take notes, which in counseling, you really want to avoid taking notes because it makes the person feel like they're being studied instead of being heard. So make sure that you are an active listener, and this is going to test your memory. So, if you have to get out that Sudoku and play some memory games, so then that way, when it comes to working with clients, you're well aware of what they're saying and you're able to retain that information in order to make your case notes later. You're going to want to have to work on your memory and your active listening skills. So then another part of it, and these are all things that you can gather if you learn how to do it appropriately within a conversation. So for example, if I wanted to know if somebody had a child, I would basically start out the session like, okay, what brings you in today? Okay, so you're dealing with issues at work. Okay, so what's going on with work? And then you can go into that, and then you can say, okay, well, what do you do at home to alleviate maybe some of the stressors from work? Do you have any children that maybe you go and play outside with? You see how you can kind of throw that in. You learn what their activities are. You learn what if they have any children. You can also learn what their presenting problems are, if they're saying that they're depressed or sad or upset about their current work relationship or their relationship with their child. These are all things that you probably do on a regular basis when you're just having a conversation with somebody, but this is actually a part of the Bio Psychosocial Assessment. So the bio is obviously, I'm going to break down the biopsychosocial, what that is. So the bio is obviously the biological causes, the psycho is the psychological causes, and the social is obviously the social causes, such as their environment, relationship status, and whatnot. So you want to look at what their presenting problems are. Are they feeling depressed, anxiety, anger? Are they suffering from grief? Have they had any major life changes like deaths in their family, moving across the country, out of the country to a new country? You want to know if they have any legal issues, whether it be themselves, their child, or their loved one. You want to know if there's any type of job problems or eating problems. These are all things that you're going to want to find out by just listening to your client and having a conversation. So that would be a part of the presenting problems. Then you want to go into the mental status assessment for identifying the patient. So what that is you want to look at their interpersonal. So the interpersonal is, okay, what is their conflict? What are they suffering from? Isolation, avoidance, harassment? You want to know what their mood is, if they're happy, sad, depressed, schizophrenic type symptoms, irritable, manic. You want to know what their sleep patterns are. Are they getting enough sleep? Are they not sleeping enough? Are they staying in bed? Do they just suffer from severe insomnia? What are their eating habits? Are they eating enough? Are they eating a balanced diet? What is in their diet? Are they binging? Are they purging? These are all things that will help you actually assess them, and you can start doing the rule out process for the diagnostic criteria. So although most of these clients, if they get this paperwork during their assessment, they're just going to go through and mark, yes, no, I feel sad right now, I feel depressed, I don't eat a lot, blah, blah. But what they don't understand is that we're, as clinicians, the professionals, gathering this information so that we're making sure that we are assessing them appropriately. You also want to know if they have any ideations of suicide, whether it be present, current, or something that, a family member has considered or perhaps attempted or succeeded at. All of these things are going to let you know the historical impact of their current condition. So these are just some of the things that you want to look at, and then you also want to put down, once you start getting all the information and the criteria, you want to put down what the DSM-5 code is and what the diagnosis specifier is. So the DSM-5 code, when you go in, let's say for somebody that is suffering from alcohol, so the DSM-5 code for that is 305.000, which I'm looking at what I had to do to actually diagnose somebody. So that was 305.00. The diagnosis with the specifier is F10.10. So what this means is this is a person that is suffering from alcohol disorder, and then it also looks at what level that they're suffering from, because there are people that are chronic, acute, moderate. There's completely different levels. There's people that are suffering from comorbidity, which chances are if somebody is suffering from an alcohol syndrome or any type of substance abuse is because they have a comorbidity, because they're probably trying to self-medicate and cope, and they're using alcohol or drugs as a coping mechanism. So most of the time you're going to find somebody that is sad or depressed or irritable that is, using alcohol or drugs as a way to cope or suppress their feelings. You also want to know, now this is very, very important, you want to know if the patient or if the client is taking any medications. So the best way to do that is don't be scared to ask your client. Like if you get the paperwork back and they have not filled that out, you need to ask them, okay, so are you taking any medications? Have you taken any medications? If you've taken any medications, or what were those medications used for? Do you take any recreational drugs? These are all important things, because if you're referring a client to like their PCP, which is their primary care physician, and you're sending them with a recommendation for medication, you need to know what their history is, which also feeds into the patient will be given a consent form in the beginning, their first session. And I know this is a lot of information, but it's very, very important. The consent, what that means is that the client is supposed to consent to you only disclosing the information that they allow you to consent. Obviously, you're not just gonna like go free and tell their whole business to the world. But obviously, if they're a threat to themselves or others, then you're liable. You are responsible, according to the ACA, to report that to the authorities and anybody else that can intervene. If they are experiencing any other issues where they're suicidal, that is where you can break the confidentiality. Also, if you are working with the patient's giving you, a client has given you permission, and I keep saying patient because a lot of times when we get into the medication part, we're dealing with a person that is suffering from psychiatric issues, and a lot of times these are people that are going to be in some type of inpatient treatment center or hospitalization. Not all of the time, but a lot of times this is going to be the situation. And so you want to find out what their medications are, because you want to ensure that you're not harming the client by simply saying, okay, I see that you have all these symptoms. Here's the medication that will work for you, without understanding that, okay, they have a history of taking this and maybe perhaps they became addicted to it. So you kind of have to be able to have that relationship with whoever either their psychiatrist, what other prescribing pharmacologist that has been supplying them their medications or once supplied their medications, that is still the person that they're under care of. So you want to know what their dosage is, the start of the day, how long they've been taking it. You also want to look at what their social interactions are. You want to see, like, okay, this person says they're depressed, but do they have a great social life? Are they interacting with others? How open are they to experiencing new things outside of just their daily routine? Because if a person is suffering from depression, chances are they might not be as social as somebody who is not. Also, there could be a person that is suffering from schizophrenia and they're saying, yes, I have social relationships, and they're, telling you about all these people that really do not exist in the real world. So you kind of have to understand when somebody is giving you, yes, I have a social relationship, you can't just take these things at surface level. You really have to dive deep to understand what's going on. Now, obviously, if somebody is schizophrenic, there's going to be a lot more things that are going to let you know that they're suffering from that, although they do a lot of times do a great job of hiding some of the symptoms. People can only hide the disorder for so long and mask it for so long. And as a therapist, you see this person more than their psychiatrist or their PCP. So you're going to be probably the first one to spot the difference in the changes in their actual interactions. So, or their moods. So you want to do that. If you have a client that seems like they're extremely depressed, they're using drugs and alcohol as a coping mechanism, that is the time to do a risk and safety assessment. So in my role play, I was the counselor and my friend was the alcoholic, and she was talking about, oh, I go out and, my friends don't want me to drink anymore and they try to do an intervention. And so immediately I'm like, okay, I have to look out for the safety of my clients. So I asked her, okay, so when you go out, do you drive? Do your friends drive? Do you get an Uber, a Lyft, a taxi? Like, kind of, how do you get about? Oh, well, usually I just drive myself because I'm not too far from home, blah, blah, blah. So right then and there, that's a point where you need to do a safety assessment and you need to implement a plan of change. So what I did was I said, okay, Well, for your safety and the safety of others on the road, I'd appreciate if we came up with an alternative. You never want to say, let's come up with a safety plan, because people are going to be like, okay, I'm not a kid. Like, we're not going to come up with a plan for my life. I got this. It's all about how you word things, and also what your relationship is with your client. So just keep that in your mind. It's all about the delivery and how sincere and authentic you are in your interactions. So, because I came about it like I'm really genuinely concerned for your safety, and I want to make sure that although we're working on reducing your alcohol intake, that while we're doing that, we want to make sure that you're safe, you're not harming yourself and not harming others, because that would be a point where if she continued the reckless behavior, where I would be well within my right if I knew that, okay, she said she's going out on this date and she's going to be drinking and driving, that I would have to break that confidentiality and perhaps contact the authorities, because I can't have one of my clients risking their lives and the lives of innocent people. So we kind of came up with a safety plan where, if she was going to drink, either she was going to drink at home, which you can't be judgmental. You know that the person's coming in with a disorder, so you can't just be like, okay, well, just don't drink. That's not going to solve it. That's going to make that person shut down, because you need to take steps, not necessarily baby steps, but you need to take steps to let them know, like, I'm accepting you for who you are, but we're just going to work on who you are. And I understand this is a process, because it took you time to get to this disorder for some people, especially for abusers of drugs and alcohol. So it's going to take you some time to work your way through it. And it's a lifelong disease. So we came up with a safety plan where she was going to either just drink at home, or she was going to call a Lyft to come and get her. So, you have to be able to have give and take with your client, and you have to be willing and open to listening to what they're saying and why they're doing it. We can't sit back and judge and be like, oh my God, don't drink and drive. That's horrible. Like, they know it's horrible. So it's not our job to shove it in their face. It's our job to help them come to the conclusion on how to navigate the change for themselves, if that makes any sense. So keep that in mind. You also want to know if they've had any sexual or physical abuse in their life, because that could also be a reason why their behavior is the way that it is. And that also, once again, gives you that historical information that you need in order to accurately assess the client. So then after you do that, then obviously you want to come up with your case notes, and you want to come up with your treatment plan. And so your treatment plan should really go into what's the subjective, which is basically you got to give the patient is a 35-year-old African-American female, and she works here, and this is what she does. And, she feels like her divorce is hindering her life from going on, and she's no longer happy, so she's drinking. What's her objective? The client's objective is to get over her husband and to stop drinking, or at least reduce the amount of alcohol intake that she takes in daily and even weekly. What the assessment is, the assessment part of the case note would be what me as the clinician would see is that the client is drinking. You want to take note of what their body language was during the therapy session. Were they making eye contact with you? Were they squirming around? Did they seem uncomfortable with certain questions? Because, like, say a person has been sexually abused, but they haven't really come to terms to speak about it. Sometimes if you even ask, their body might shift in a certain way. So all of these things you want to note, because please keep in mind that your case notes can always be pulled for legal reasons. So you want to make sure that you're being very precise, but you also want to make sure that you are concealing the identity of your client. So just in case for some reason their paperwork got out of your hands and into the wrong hands, somebody could not pinpoint who that was, because once again, remember, you're going to give that client a number, not a name on their intake paper, their biopsychosocial intake paperwork. And then you want to come up with a plan. So the great thing is goal and objective setting. So goal setting. Goal is kind of like the broader aspect of what you want to get done. You're like, okay, so my goal is I don't want to drink anymore. Okay, that's fabulous. We love that. We don't want you to drink anymore. And so you want to say, okay, that's your goal. What are your objectives? So you might want to say, okay, my goal is I don't want to drink, and my objective is that I want to reduce my drinks from 3 bottles a week to 2 bottles. And that's progress. You know, you can't just think somebody's going to be like, oh, I go from drinking a whole case of beer to like I'm only going to have 1 beer a month. Like that's just a client that's going to tell you that. They're probably telling you what they think you want to hear. And so the objectives are going to be concrete, detailed, and measurable steps. So you want to be concrete. Okay, so you want to stop drinking. Oh, you want to reduce your drinking. So, okay, this week is, the 2nd week of June. So by the 3rd week of June, we have another session out on Friday. What do you want to have accomplished as far as reducing your alcohol intake? So what I would do is say, okay, how many bottles of wine do you drink in a week? And the client might say, okay, on average, I probably drink about 4 or 5 bottles of wine a week. And so I'm like, okay, how many bottles of wine do you currently have in your home? They might say 6. Okay, so you have 6 bottles of wine in your home right now. At the end of this week, without buying any new bottles of wine, how many bottles of wine would you like to have left? And so they might say, oh, well, I really hope to have still like 4 bottles of wine left. Okay, that's progress. So their goal is measurable, concrete, and detailed. It's measurable because obviously at the end of the week, if they have 4 bottles of wine still left, that means you can measure their success by that. It's detailed because they're saying, like in this instance, she only wanted to drink 1 or 2 glasses a night of wine instead of 1 or 2 bottles of wine a night plus shots of tequila. So we're already talking about you are willing to try and eliminate the shots of tequila, and you're willing to reduce the wine intake by 1 or 2 glasses instead of 1 or 2 bottles a night. So that would be the objective of the goal. So think of the goal as the big picture. The objective is the smaller, more detailed goals. Okay, and so just kind of reading off of like some of my notes here just to make sure I'm getting everything. So if I'm not looking exactly at the camera, it's only because I'm trying to make sure that I'm giving you guys if you're taking this class or you're interested in this field, that you're kind of getting an understanding of how detailed you need to be. But keep in mind, as you do the goals and stuff with the client is in control in a sense of their own therapeutic success. Not in a sense they are, but you are working collaboratively with them. So you need to be able to build that dialogue and still be showing the basics of empathy, understanding. You want to ask probing questions. You want to do all of those things that lets the client know that you're an active listener and you're actually caring about what's going on in their life. Because take it from somebody that's actually been in therapy, because in my last video I talked about that. And I literally fired this chick because I could just tell she didn't care. Like, it was so obvious. I'm like, you're not about to get any more of my money. You're horrible. And I told her, I said, thank you so much for telling me and, showing me everything that I should never do with a client because, honey, you're horrible. Horrible. And so, I would definitely recommend, because what helped me do these role plays is going to therapy myself. Because before then, you can read, you can write, you can watch videos all day long. You can watch me talk about it all day long. But I would highly recommend, and trust me, it has taken me all the way to this point to even do this. I would recommend going in, either doing the teletherapy like I did, or finding an actual therapist and just going to a couple sessions, because it will help you naturally learn how to do this yourself. Before, I felt like I was very robotic because I wasn't really sure how it looked and how it should feel. And so it's great to be on both sides of the coin, where you're the counselor and the therapist genuinely. And so I'm like, oh, that's what it looks like when you're being a robot and not sincere, and you're trying to like click off everything in your mind. Like, okay, I asked them this. Oh, I showed empathy. Yes, that's so sad. Thank you for telling me. Like you can tell. And so it really actually helped me be a better therapist. And I was like, whoa, I did not think it was going to do that, but it did. So I would completely recommend going and doing therapy if you have not done it before, because it will give you that experience, and it'll kind of like shake off the jitters of being new. Like if this is like me, my background is in business and marketing economics, which I'm currently still working in a job that's kind of semi-related to that, but still in the health industry. And it will really help you become more authentic in changing from one career to now this being your career. It really will. And until you do it, I really can't even stress that enough. But I would just say be open to even going to a few sessions, just to kind of see what that feels like to be in therapy, because you want to be empathetic, and being empathetic is having some sense of understanding of what the client is going to be feeling when they're in therapy. And guess what? You're nervous and they're nervous. So you're both nervous. Nobody knows each other. Everybody hopes that you get along. And also, when you do become a therapist, like if somebody just doesn't like you, I know this is going to sound really bad, but don't take it to heart, because this is a human field and you have to connect with somebody. So if you have a client that's not connecting with you, and they're just, no matter how much you feel like you're trying and you're being genuine and you're just like, but I'm giving you my all, don't take it personal. And if you have to play that a million times, don't take it personal, because it's like being in a relationship. It is a relationship. If you don't have that chemistry with somebody, it's not that maybe they're not a nice person. This other person I wish does not, but it could just be the chemistry's all off, because it's another relationship that has to be worked on. But first, you need to have a basis of understanding and acceptance from one another. So, I would just say that making sure that you understand the therapeutic process, the assessments, the treatment planning is very imperative to the success. And the treatment planning will also help you not only with the client developing goals, short and long term, because remember, you don't want to have a client be in therapy for the rest of their life, especially if they're suffering from something that it could be, worked through therapy, like depression or anxiety, stuff like that. The ultimate goal is to get the person to live a very successful, healthy, normal life without being dependent upon their therapist. So keep that in mind as you progress. The pharmacology aspect is the psychopharmacology aspect, which I was like super excited, because if you don't know, I had got accepted to pre-med, but this just worked out better for my lifestyle, because let's face it, honey, I still needed to make some money while I went to school, and like dropping completely out of the working world just to strictly concentrate on going to med school was just not going to be feasible. So yeah, but you know what? I still feel very happy with where I'm at, even with all the multiple challenges. And as I am approaching my second residency in a month here, so I can't wait to do an update. I'll try and do an update while I'm at residency, not like actually sitting in residency, but like maybe in the hotel room to give you guys kind of like a in the moment update. But residency is very, very draining, so I can't promise that. But you can always look at my last year's residency video when I came back. When I came back from Chicago for a week, and you know, it is very draining. And I'll kind of leave it at that. But you know, the pharmacology aspect is so important. Although we're not prescribing medications, you need to know what your client is taking and how that's interacting and how that plays a part in what their symptoms are, because you could have a client that is, you know, taking some type of medication for their anxiety and it's creating hallucinations, and you might misdiagnose them with acute schizophrenia or something like that, and you're like, okay, now they're not off the medication. Now they're not having hallucinations. Now that's just a thrown out example, you know, probably a horrible one, but you get what I'm saying. You need to know what their medications are. You need to know what are the not only normal side effects, but even those 1% side effects, because you could be dealing with a client that's suffering from that 1%. So although you are not a medical physician, you are partnering up with medical physicians in order to make sure that the client is receiving complete care. Now, I do strongly believe in holistic therapy, and that's not to say that like anybody taking medication, I'm like, oh my God, I'm so against you. But I don't think that medications for certain disorders should be relied upon so heavily, like for anxiety and depression, because it could actually cause even more anxiety and depression. So you know, you want to make sure that you're coming up with treatment plans and resolutions that don't just rely on the psychopharmacology aspect of the therapeutic process. You really want to look at what will make this person whole without feeling like I'm helping drug them up with things that will suppress the symptoms instead of really helping them navigate and really discovering what's going to be the best mechanism to cope with what's going on and actually find resolution. So I hope that this video, you guys kind of got some information out of it. I hope I didn't overwhelm you. You can always ask me questions. I try to answer the questions, but I'm going to be very truthful. I don't always get to them, and I know that's super horrible. I will try to do better, but school work and trying to revamp 2 businesses, I've been very, very busy, so I do apologize. If you pose a question and I haven't responded, it's not on purpose, I promise. I just don't really look at my notifications as much, but I will try. And I hope that you guys are enjoying whatever program that you're in, or that this has maybe given you a little bit better insight of what it means for treatment planning and the Bio Psychosocial Assessment, and goal setting. Remember, the goal is the biggest thing. The objective is the measurable part that's smaller of the goal. So just remember that you got this and that you're going to be successful. And a year ago from now, I was a nervous wreck thinking like, what have I gotten myself into? And I still am some days. Like, I'm not going to lie, I'm not officially like a therapist. I'm not treating anybody, but I do feel a lot more confident in what my skills are. And just stay confident and, you know, tread above the water as much as you can, and you will make it. So I hope you guys love the video. And I will see you guys in the next one if I don't see you in the chat room. Bye, guys. Like and subscribe and share the video. Bye.